Where you currently are in terms of the work you're doing and so on.
Okay. My names are Dr. Bruce Dahlman. I'm a family physician by clinical training. I spent my first several years in a very remote part of Minnesota, USA, and then our family moved to Kenya, East Africa, to a 200 or so bed church hospital called Kijabe. And we were there for a total of 9 years, and then in East Africa for a total of 14 over the last 24 years. So East Africa is our second home, and working there both in clinical work as a family doctor, but then seeing the needs for good training for primary care. I've gotten involved in developing family medicine postgraduate training programs, so training family doctors.
And your specific interest in M Health?
Well, it came from that need. We were trying to encourage family doctors to be lifelong learners, to be patient-centered, and asking them to consider being the consultant to the primary healthcare team in the usually less served areas. Almost all of them are rural. Once you get past a university center, where do they go to find information? Where do they where do they get the help to be answering the questions that are prompted from patient care? So we felt we needed to develop something that they could utilize both in training and then take with them as they go on into their practice. So from that we worked on an app, developed an app called the Digital African Health Library, which is basically a collection of what we hope are best of category types of resources that are integrated into a search engine so that they can use one search term to look up information in many different resources at once. And within the research, we know they won't look something up unless it's less than 2 or 3 minutes. That's all they give themselves to find new information. So it has to be pretty well integrated and to be able to get to that information. Yeah.
And what sort of information does it contain? I mean, is it guidelines and stuff like that? What is it?
Yeah, so our technology partner is MedHand International from Stockholm, Sweden, and they had been working with a contract with the Oxford publishers in the UK for their handbooks, which are pretty much the standard in our Eastern Africa part of the world. And so that was the core of things. They also had some other resources like the British National Formulary. But to that, we really felt a need to obviously Africanize the resources, make it more locally relevant. So we have embarked on working with the Ministries of Health, starting with Kenya, where we're based, and given permission to take their PDF forms of their guidelines, which are available online for anybody, but make it into an XML form that integrates with the rest of the search engine so that it incorporates the findings from I call it the hyper-relevant resource right into the search of what they're looking for. That's pretty important, especially for mid-level health practitioners, the clinical officers, nurses that are the front line of healthcare delivery in almost all of our sub-Saharan African countries. They need to know what the guidelines say they should do for usual diagnosis. So we felt that's pretty important to have that authority base from the ministry, as well as the really heavily evidence-based resources that we try to use for our medical officer and family medicine doctor clientele. We use there a resource called Dynamed, which is I call it PubMed in your pocket. It's taking the latest journal literature and they're condensing it into a very manageable bullet point form, inserting it into the database so when you look up the diagnosis and treatment of something, you can find it all there and you can scroll through basically all the latest literature on the topic, updated in Dynamed every night. We do a monthly update for our customers so that they're getting the latest. And that's really important in some areas. It isn't always necessary because the resources are not always there. But you find that things like, we call them treatment guidelines. You can diagnose an ankle sprain not being a fracture if you know the Ottawa ankle rules, as an example. So high tech can sometimes mean better care in low resource if they know how to access those kinds of information.
And how do they access your app? Is it on mobiles or
Right.
laptops, or how does
Yeah,
it
well,
work?
we focus only on mobile,
Okay.
and the intention there is that patient care prompts a question in a user's mind.
Okay.
So a practitioner is taking care, and then a question comes to mind. The app needs to be, in their hand there,
Right.
so that when they look up the answer, they can turn around and the patient that is in front of them gets the benefit of the new information.
Right.
So in our original studies, looking at the pilots of this, that information changed their plan for what they were going to do in their care up to 20-25% of the time.
Sure. Okay.
And from that, some people, they felt, gained a better outcome because of the information they gained. That's crucial to best practice then.
Absolutely.
And if that habit is reinforced continually because they can get to an answer most of the time, well, then patients we are expecting are then getting the better care.
Yeah. And do the healthcare workers have to register to get your app, or is it freely available? And do you know who's got access to it?
Right. So it's available as an app in the Google Play Store,
Okay.
and anybody in Africa is able to download it. Now there are security features so that those outside of Africa don't even see the app, because it's important for the some of this is proprietary information that we've gotten generous donations from them in terms of discounting the price of their product, and it obviously would not be fair to the company to have this go outside. So it's meant as a focus for Africa, and then we have a registration system to be sure that your IP address is from here and your phone number is from here and so forth. And that way we're able to ensure for our product partners that the users are indeed from the target audience.
It's not going just as wide.
Not going wide, because we are discounting heavily from the...
And training, I mean, is it something anybody could use, or do you
when we first started piloting this and giving it to people, we loaded it on phones and said, gave them a few pointers. But these days, the public is device literate. They know what to do and how to do it if you can make it intuitive enough for them. So we do have more thorough instructions for people to get the best value out of what they have. But for the most part, people pick it up pretty quick. Yeah.
I'm sitting here wondering, you say clearly that this is aimed for Africa and African context. Now, I'm from Sweden, you're from the US, and you've been practicing in the US. I think in both these countries there are huge rural areas with similar condition. However, we will not call them resource limited because there are rich countries. But wouldn't applications like this and mHealth in different forms be as applicable in these countries, in the rural areas, as here?
Sure, they are. And the parent companies, so for instance Oxford, the original bed-hand contract with Oxford was to give practitioners in Sweden access to, I think, 140 different possible books that they could load onto their device and so forth, but at retail prices. So the value add that we're bringing is one, integrating a collection of about 10 resources at once, hopefully best of class or category. So we have a formulary, we have handbooks, we have the guidelines from each country, currently from Kenya, but talking at the meeting here, meeting the Minister of Health of Malawi and ICT Minister for Uganda. Obviously, they look at this and they see,
they could use.
This is what our people need, and what we want to do is be sure that their guidelines are a part of this package, so that when the nurse in rural Uganda opens it up, she sees Uganda's, guidelines for malaria or HIV treatment and so forth.
No, because my thinking is that if we extend this beyond maybe just information and look at these image-based applications and so on,
yes,
that if they would be interesting also for resource-strong countries, that a lot more investment money could come into it, that would, so you could say, creating benefit for the rich people would automatically benefit the poor people.
It's a very, obviously very, forward-looking idea, and certainly we have to look out for the models that are going to work to make, this happen across Africa. These are highest value products that really have worth that you can't just say, well, just give it for free. All right, give it for free means, does the person really value the information that they're using then? Really? Do they? I mean, I think there has to be a point at which Africa takes ownership of, utilizing best of breed for best practice and wanting to do it. That's a paradigm shift, though, because most information in the way education happens, and still in the West as well, is sometimes authoritarian based. The professor knows, and you have to learn what the professor knows, and that's it. But I think more and more education is moving to this evidence-based, kind of model, so that you're encouraged to be questioning, encouraging the looking to the next step and helping the professor make a better decision as well. That's going to take a while, but that paradigm shift has to start somewhere.
Yeah, I mean, I think it's happening in many other areas. I mean, when I was in university, information that was my own had a value. My kids would claim that information that is not shared is completely useless. So I mean, we see that in the next generation coming up, they would expect a lot more of transparency and sharing.
Yeah, I think that's true, and of course the family medicine residency programs that I've been involved in helping to start in Kenya and advising in other places. We are trying to help make that the core of how this learning happens. So we invite questions to be asked and answers to be found and then discussed in a small group that helps bring that ethic of what it means to be a doctor in the 21st century. And hopefully these tools are at least a part of that solution, to making that question asking best practice, the way that doctors want to practice.
How far have you rolled this out?
So we have a couple hundred users, mainly in Kenya still. We've been able to automate the registration processes, and one of the significant barriers is payment. Okay. So if you're gonna sell anything in Africa, in the West you have your card and you use your number on the internet or wherever. Well, the average clinician, even physicians, don't necessarily have a bank account even. That's a service that actually has a lot of costs. So as you might know, in Africa, we're actually the leader in utilizing mobile money.
M-Pesa.
So M-Pesa in Kenya was basically the start of the whole revolution. So we're utilizing those services so that once they've had a 1-month free trial of the product and can see what they're looking to purchase, they can punch in their M-Pesa payment, and that comes through the M-Pesa system to our bank automatically. We don't even see that. So it works quite slick for Kenya, and we've also have a service that's working in our neighboring East African countries, Uganda and Tanzania. But we haven't really rolled out there too well yet, but that's our hope, and yeah.
And besides the fund or the payment issue, any other major challenges?
Yes, evidence-based medicine as a way to practice is it's a cultural, educational, and barrier. It's something that isn't there.
And yet it's so obvious.
Yeah, it seems so obvious that you'd want to have information. Yeah. But, if you memorize what the professor told you in your internship, and you think you have it all figured out, you know, you have, it's a certain amount of, well, as I tell the residents in the first day of their coming to the residency, I say, to learn means to be humble. All right, I don't know. You have to say, I don't know, before you go looking for an answer. And that's the first big step, because after you've been through training and you've been basically conditioned to not let the professor know that you don't know. Well, if that's the way you've been conditioned and you've been out practice for 2-3 years, you have a pretty good idea of what you think goes on. So to bring
and doctors are supposed to know.
We're not the most humble group of people. So you're starting from behind the 8 ball there, yeah? So you got to be humble, you got to be curious, you have to be persistent because information's hard to find. Those are all 3 traits that are not easy, you know, when you've got to queue out the door, you know. So it's an uphill struggle, you know, to get this paradigm.
The literal shortage of healthcare workers in these kinds of facilities. I mean,
well, shortage in numbers and shortage in actual boots on the ground. You know, sad to say, but there are many places where, you know, there are names on the line for who should be there, but for many different reasons they're not. And so patients, you know, have to go long distances geographically. And then we know also from research that if there's not a perception of quality occurring, you know, in a place, they'll walk past, keep going to the next place they think is quality. So there's lots of barriers to excellent care, but having the family physician as the consultant to the team is hopefully somebody who now can anchor that and be an encourager to the rest of the team to do best practice and be a part of doing the working on things like process improvement and so forth, so patients have a better experience and really want to come here. So yeah, quality of care, process of care, all those things, you know, I think, you know, can over the time improve a lot. You know, when you have dedicated people who are there to serve. And if you have to put a parenthesis around everything that I've said, it doesn't really matter unless you're there to serve.
Exactly. Yeah.
And
the right reasons.
Yeah, that's hard sometimes when the pressures are so great. Yeah.
Anything else?
Well, talking about process improvements, some reflections and ideas around this roundtable format.
Yeah, the STIAS Roundtable is a very unique experience. I've been in a lot of meetings over my life, and this is definitely a very unique setting for bringing together people, and I really appreciate the interdisciplinary approach, you know, so we're meeting with different people on our tables to discuss and realizing, you know, the issues from different angles, very important. And, you know, I guess I learned a while ago that yes, the meeting content and what we put out, and there'll be some paper that's published and we'll all agree this is a good thing, but bottom line, it's meeting the next round of a network, you know, to see what others are doing and finding best practices that you can then take home. The networking is an important part of these always, and you know, meeting people like yourself, Jan, you know, it's just excellent, and these are the kinds of things that help strengthen the relationships that then can be built on for incorporating each other's ideas.